Committee's commitment to oversight of our federal investment in the electronic records system world and continued work toward achieving the goal of interoperability. This is a $35 billion federal investment in expanding the use of electronic health records. And it was sold on the promise of improving care and lowering cost. I think we've all said that and understand that. Many doctors have adopted this technology, whether they wanted to or not, and are seeing benefits that the majority of docs that I hear from in Kansas tell me that the administrative burden on them is taking away from their time with their patients. A Wichita doctor told us we're basically key punching operators, transcriptionists, having to input the data ourselves. That has essentially tripled the time to complete a medical record. How on earth do you accomplish that when you're already working 12 to 14 hours a day? Well, couple this individual but common plea for relief with a medical economic survey from last year that says nearly 70% of physicians think their electronic health systems have not been worth it. And you can see the real problem that we're facing. Obviously, the system needs to work for our providers. They need to see the benefits of improved care coordination to validate their financial time and investments. Dr. Washington, are you able to quantify or estimate how much of your doctor's time is spent on functions, or as you say in your testimony, checking boxes that prior to our electronic system, nurses or assistant staff would otherwise perform?
Senator, I'm not sure if I can actually quantify that. It's certainly in our studies, we've done studies on how long it takes to do transcribed medical orders in the hospital versus electronic orders. And it's certainly the overall time of the physician at the computer to do that has increased. I will say when I talk to physicians about adoption in that space, though, that the clinical decision support tools that are within those EMRs, that are the safety tools, really only work if you as the provider are inputting the data. So you get those alerts, you get those directions from the computer to do those activities. And once you place an electronic order in the hospital, every division in the hospital that needs to act on that order gets it right away, as opposed in the old days when I practiced where you would do rounds and you would depend on the unit secretary to take your chart down, and you may be fourth or fifth in line depending on what was going on before that order got sent to lab and some other places in the health system. But those are in some ways the trade-offs that happen. But there is certainly a burden that's been increased by the electronic health record. The balance in my mind is to try to make sure that there is some value around the clinical decision support and things that we didn't do as well on paper.
Okay, let me ask you the obvious question. Do you think there's some documentation that nurses and other physician extenders can do as part of the care team and to reduce the time burden on physicians?
Yes, and in fact, one of the things I was trying to reference in the testimony about billing is that there's a requirement now that we had literally trained on last week that as a provider, I have to go behind a scribe or a technician and attest that a document that I'm already signing electronically, that I agree with what they've already documented. And that is all in the sort of billing and regulatory perspective. So a review of systems requires an attestation by them, an attestation by me, and a signature at the bottom of the record in order to pass the billing hoops. To me, that takes away the advantage of having those folks practice at the top of their license.
I'm concerned.
Could I comment as well?
Yes, ma'am.
You know, we did a survey on our physicians last year about their satisfaction with the record, and it was not good. They said that they were working until the evening, and when we really investigated, what we found was that the record itself drove all the work to them. I don't know if it was because it was a documentation tool to begin with and like a glorified progress note, but we spent the last year ripping that apart, and now our doctors do not do that. We've created workflows where nurse care managers and pharmacists and medical assistants do that kind of work. And we're going to be surveying our doctors soon, and we're really hopeful that they've felt a tremendous difference.
Let me ask you a follow-up question on that, Ms. Moss. From your experience in upgrading and implementing the systems, the EHR systems, what's the range in financial costs you are anticipating in transitioning from state 2 meaningful use to stage 3?
I can't answer that. I don't know, sir.
Well, there you go.